All right. Hi, everyone. Thank you so much for joining us today. So we have another educational series event for the Huntington's Disease Society of America, the San Diego chapter. We have two really great speakers today that we're happy to bring to you with a lot of really great information that I think all of our Huntington's families will benefit from. So, Kristin, I'm going to go ahead and hand it over to you.
Thank you.
If
Thank you,
you
Kim.
want to go ahead and tell us a little bit about who you are and what you're going to talk about today. We have had you as a speaker before, and so it's my understanding you've done the first part of this presentation. You have a lot of really great information. You have it kind of broken up into two presentations. Tell us also a little bit about what you're going to be going over today.
Sure. Well, my name is Kristin Rigsbee. I am a regional coordinator with the Long-Term Care Ombudsman program here in San Diego. And I have been working prior to becoming an ombudsman as a case manager in skilled nursing facilities for probably about 20 years or so. I also have been in memory care units in assisted living, had my administrator's license for assisted living, and then also worked for an elder law attorney. And so kind of what brought me to the ombudsman program is I had wanted to work with the county. And I was looking around and actually applied for a different job, but with my background, they actually had a position that wasn't even posted yet for ombudsman. And so they actually called me to interview for the position I'm in now. And so I always thought when I retired, I would become an ombudsman. And I was like, oh, this is awesome. Because it's actually much more of a better position for me than even working in the facilities. I was actually let go from a facility because I would not basically discharge all their custodial residents on Medi-Cal to other facilities.
So tell us a little bit about what the term ombudsman means, because
sure.
That was my first time hearing it when I heard you speak the first time, and I was like, wow, I didn't even know that this was a thing.
Well, our program has been around since about 1970. So back when Medicare first started and Medicaid, you didn't have assisted livings or board and cares. You only had true long-term care facilities. They were not rehabs. They were just places where basically where residents admitted were there until they died. And that's where the I don't want to die in a nursing home kind of came from, because that's what happened. Once you went into one, you didn't come out, in a sense. And the problems, there were lots of problems with these facilities because at the time, no one actually was representing the residents. Nobody was checking on them, and many of them had no families to even be checking and make sure that they were doing okay, that their concerns were addressed. And so it was actually put in, the ombudsman program is a Swedish term for advocate. And there are lots of different ombudsman programs. There's ombudsman for the DMV, there's one for the military, there's even one for mobile home parks. But an advocate, as for us, was to solely represent the resident, not the facility, not the family, not any other organizations that a resident might be involved with, but to truly make sure that the voice of the resident is heard and that they're receiving the care that they need. And so our program was actually put in as a pilot. And one of the federal mandates was that it also be volunteer, because they wanted no conflict of interest between the person acting as the advocate and the facility. So they didn't want someone who, say, worked in the facility who was designated as the patient advocate, because that person couldn't really be truly advocating for the resident because their job was there.
Mm-hmm.
So even people who work in other industries, like if they're home health or hospice or any other kind of industry, also cannot be an ombudsman, because there is that financial connection. Like, oh, you're an ombudsman, you can send us all the referrals or tell us what's going on.
Mm-hmm.
So all of our ombudsmen generally are volunteers. We only have 11 staff in our whole program, and we cover all of San Diego County. Because this is a federal program, no matter where you go in the United States, every single skilled nursing facility, assisted living, and board and care have an ombudsman. So there are actually 35 programs within our state. And one of the basic sort of guidelines for our program and our ombudsman is that, one, everything that we hear from residents is confidential, and or families or anybody. Whoever discloses information to us, it's confidential unless they give us consent to talk about it. So if we get a concern from a resident, unless we get their consent to help them with that situation and be able to disclose that information in order to help them, then that's where it stops, in a sense. We're not going to disclose anything. We are not mandated reporters. So a resident who discloses something, we have to be very creative in how we can try to help them. Now, they may want our help, but not want their information used. And sometimes we can make an impact on that without disclosing who it is, but it's really challenging, especially if there's something very specific to a resident that if you even mention anything about it, they're going to automatically know.
Mm-hmm.
So it's hard because residents and families are very afraid of retaliation. That is very, very huge. And it is a legitimate fear because retaliation does happen. Mm-hmm. So oftentimes there's not really retaliation when someone notifies the ombudsman, mainly because they know that we're involved. We know that we'll inform residents and families of their rights, and that we will intervene if there ever is any issue. So most of the time there isn't any retaliation, but that fear is huge.
Yeah. And I'm sure it's helpful for you to kind of facilitate the communication between the facility and
and that's our goal. Our goal is to not, in a sense, get the facility in trouble, mm-hmm. but to help the resident, because we want the resident to be able to verbalize what their concerns are to the facility. Mm-hmm. We're not going to take over and just handle it all for the resident. We want the resident and the family to be involved in this process. To, like, if I do a care conference to discuss a resident issue, the resident is there. And I have them talk about what their concerns are. And that way everyone is hearing the same thing. Everyone agrees on a plan to address the issue. And because everyone knows about it, then if something isn't happening, we can come back and say, you actually agreed to do this. This is what the plan was. And so, there's not that hiddenness about things, or I'm telling this person and I'm telling this person, and it's all over the place. So it's everybody's on the same page. It's out there as a legitimate issue, and most facilities prefer to do that. If you can solve an issue, because so many resident issues are not regulatory.
Mm.
So basically, a complaint to the Department of Public Health or Community Care Licensing isn't going to resolve the issue, because the actual issue has nothing to do with regulations. It may have more to do with a resident's preference about something, or
That
a
was
way they.
that was another question I had. Could you give us an idea of maybe like what sorts of things you get involved in, or how little or how big are kind of the issues that you're helping people with?
Well, we deal with everything from something as simple as I want eggs every day for breakfast
Mm-hmm.
to major abuse. We do the abuse investigation in all of the facilities, as well as licensing and law enforcement. So we're all three involved in investigating abuse.
Mm-hmm.
So we handle any issue that happens within the facility, no matter what it is, whether it's financial, whether it's a care issue, whether it's an abuse issue, or just personal preference of things that somebody would like to do that make a difference in their day.
Okay.
So we get involved with everything that goes on in a building.
Well, I won't keep you from your actual presentation. Sorry if I kind of sidelined you a little bit.
Oh, that's okay. I talk rather, I love talking about our program and what we do.
Yeah.
So I'm more than happy at any time to answer anybody's questions if they have any. And I'm more than happy to give you my cell number. And we want to make sure that questions people have get answered, and that they're also aware of what things that they need to know ahead of time.
Mm-hmm.
All right, so I'll go ahead and get started here. So what this presentation is going to be about is sort of the second half of what do you need to know before you would go into an assisted living or a board and care situation. Because many times people don't really understand how the whole system works. So we're going to talk about kind of what is an assisted living level of care, what services they provide, what levels of care can you receive there, the big questions, how much does it cost, how is it paid for, are there any resources and ways that we can evaluate a facility before we would have a loved one go there, and what resources, if somebody, say we're at home, are there. So you'll often hear assisted livings, board and cares, RCFEs, all sort of lumped together. So basically the overall term for an assisted living level of care is called residential care facilities for the elderly. So that is assisted living, which are generally the large buildings. Then you have board and cares, which are licensed under the same. They provide the same care. In many ways, they can often provide more care. But they're small 6-bed homes out in the community. Then you have another level of care, which is the CCRCs, the continuing care communities, which are the buy-in to a multi-level care type of facility. Very expensive. So you'll hear those terms interchangeably. You'll also hear terms like memory care. Now, generally, when people are referring to memory care, they're referring primarily to an assisted living memory care where the facility is designated for only residents with dementia. But there are memory care units in skilled nursing as well. So you have to kind of ask which level of care this is. Okay. So basically an RCFE, they provide overall supervision and assistance with activities of daily living. So you're dressing, grooming, hygiene, bathing, those kind of things. They can assist with medication. Now, one of the things that is kind of like a nuance here, they cannot administer medication. They can only assist with medication. So for someone who, say, is diabetic, is one of the biggest issues and needs insulin injections, the resident has to be able to do the insulin injection themselves. The facility cannot actually inject the resident. They can assist with drawing up the appropriate dose, assist with the finger stick. They can assist, but the actual administration of the medication, the resident has to do themselves. So they can put your medications in a cup and hand them to you, but they're not going to administer them to you. So it's kind of a fine line technicality there. The facilities also will contact the MD, help set up labs, take care of the pharmacy. Some usually use an outside pharmacy that deliver medications to either the board and care or RCFE. They can do also minor skin treatments. Now, we'll go over in a little bit about prohibited conditions in RCFEs, and that falls into one of those categories. They can help provide transportation to appointments. They are not required to provide the transportation. They are required to assist in finding transportation. So some facilities have their own van and they can set it up that way. A small RCFE, some of them actually will take their residents to doctor's appointments, some don't. So that's an important thing to find out if transportation to appointments is an issue. Okay. They also coordinate with hospice. Many times, especially in large facilities and even in some of the small 6 beds, they charge an extra fee if a resident is on hospice, which is always funny to me because hospice helps with so much of the basic care as far as helping with showering, calling the doctor, taking care of things, but the facility will often charge you an extra fee if you're on hospice because it does take time for the staff to communicate more with the hospice staff. So that's kind of their justification. One thing I want you to keep in mind is about RCFEs in general is they are non-medical. They are not required to provide a nurse or any medical professionals at all. They are actually licensed by the Department of Social Services. So when these facilities were licensed, pretty much the residents that are in these facilities now would have been probably many of them in skilled nursing facilities as long-term custodial residents. When the regulations were written, most of the people in assisted living were more the type of person who maybe just is not safe to be at home alone, but can still function and do everything on their own, but maybe they just need some help with showering, they're not safe. They maybe need some help with medication, but they can dress themselves and do everything on their own. Now, residents are needing many total care, Hoyer lifts, different things like that, which would be a custodial resident in skilled nursing normally. So unfortunately, regulations haven't caught up to the residents that we're seeing in the facilities now. So when someone starts needing a lot more care, then you have to kind of look at, is the facility really able to provide that level of care? So it's super, super important. Okay, so these facilities are licensed by Community Care Licensing, who surveys them annually and goes through making sure that they are in compliance with regulations. They also come out if there's complaints filed against the facility. And we'll talk a little bit more about that in a minute. So one of the biggest issues with assisted living is, what can you afford? And that determines, in a sense, a lot of where you can go. So you have like a small 6-bed on one side and these large communities that look like almost hotels. They cost very different. So you might have a private room, or you might have to share a room with another resident. So how much does it cost? This is always a huge issue. Generally, most board and cares and assisted livings are about, the minimum is about $4,000 a month. There are some that are a little less than that, but not many. It can be as much as $12,000 a month at some of these very high end, and if you need dementia care, it's even more. So it can be a huge cost per month to have someone in the facilities. So when someone is admitted, all of these costs have to be spelled out to the person in their admission agreement. So you want to make sure when you sign an admission agreement that the information that you're signing is correct. So many large places will give you a deal for a while and then they change it. You want to make sure all of that is correct on these contracts. Okay. So all the fees that they charge have to be fully disclosed to you. So if many facilities charge a basic room rent, and then they charge what they call care fees. Now, some do individual fees, some do tiers of fees. It sort of depends on the facility. Board and cares generally combine their room rent and sort of care fees, and this is just what it costs to come here. Even some of the board and cares will have extra fees for different things such as hospice, incontinence care sometimes, because that can be very timely and costly for depends and things like that. Some will have family members bring in the depends. Sometimes the facility provides them under the fee. So it's important to look at all of these different things that may occur before someone is placed in a facility. Okay. If you need to have assistance walking to meals, they're going to charge you for that. Medication administration is not usually just a flat fee. It's oftentimes based on how many medications do they have to administer and how frequently do they have to do it. So if you have a med that you need to get 4 times a day versus a med that may be twice a day, you're going to pay a significant amount more because of that. Any assistance with dressing and grooming, some will charge for laundry, many don't. They include that. Transportation, they're not required to pay for that. Now, large places often have transportation for free because they have a van, but that is going to be a cost in many facilities. So you have to talk to the facility about the transportation and what or if there is a cost and what's involved. If a person has dementia and is not able to really handle a doctor's appointment on their own, someone has to go with them. So you may have to pay for a companion to go with the resident if family is not able to go. So it can add up to a lot of different prices. So there are conditions which a board and care or assisted living is not allowed to have within the building. So one is any in a sense commutable diagnosis such as tuberculosis. If you had even for the longest time, if you had what's called C. diff, which is an intestinal infection, now they've made it a little more lenient that the person can isolate within their room. If anyone has stage 3 or 4 dermal ulcers, so a facility can keep someone there if they have a stage 1 or 2 pressure sore. They can that can be treated by home health, not the facility. If they become stage 3 or 4, that's an automatic discharge. They are not allowed to keep that resident there. So they have to send that person out. This is where we often find that assisted livings and board and cares are not sending residents out when they need to, because they keep them there and they should be sending them out and getting them placed somewhere else. Okay. These infections in these board and cares and assisted livings, when they don't have staff that really understand what they are and how to care for them, become significantly worse. So that's one of the biggest issues that we find. If someone has a feeding tube, even if they can manage it themselves, they are not allowed to be admitted into an assisted living. If they have an NG tube, which is usually fairly temporary, they cannot. Anybody with a tracheostomy, even if they are totally independent and are not on a ventilator and they just have the tracheostomy, they cannot be admitted to an assisted living. Anyone who is fully, totally dependent with their care, so basically someone at this point who is comatose or totally paralyzed and can't do anything at all on their own, even with assistance, is not able to go to an assisted living. So licensed professionals from home health or a hospice agency, they are required to provide the medical care that a resident would need to manage things like a skin issue, to manage things like a Foley catheter, or if someone has a urostomy or an ostomy, to be able to help manage those and make sure that staff have been trained to do that. They can also do some of the injections. So some of our large assisted livings especially have their assisted living director usually a licensed nurse. And so they can then do any injections if a resident needs it. It also is a very big marketing thing, because they make it sound like they can provide more medical care and supervision than they really are licensed to do. So you have to be really careful with the marketing side of things. So how do you pay for an assisted living? So the biggest thing is private pay. There is generally not a whole lot of assistance when it comes to paying for assisted living. If someone has a long-term care insurance policy, that can help cover assisted living. It doesn't usually cover the whole thing, and many of them now, you have a 90-day period where they don't cover, and you can start after 90 days. So it's important to read through any policy you have and see what do they actually cover, and when does that coverage start? Because paying 90 days can be an awful lot of money. So if you're not aware of that ahead of time, it's important to really find out, because that could be a major stumbling block. Now, for somebody who's very, very low income and qualifies for Medi-Cal, we have here a pilot program called the Medi-Cal Waiver Program. Now, the problem is this program is so full and overloaded with people that there haven't been any beds available in a very long time. And last year they legislated 3,500 more beds, but that basically took up some of the people on the waiting list. And the waiting list is now very, very long. So these are facilities that are willing to accept a Medi-Cal resident and the rate that Medi-Cal will pay for that resident. So generally you're not looking at large assisted livings, you're looking at smaller board and cares in the least costly facilities. So it can be a challenge. Now, if someone makes more than $1,400 a month, then even if they're on Medi-Cal, they automatically don't qualify, because $1,400 a month is where they've capped it. Unfortunately, you're not going to find an assisted living for $1,400 a month. I don't know how they came up with that figure, but here in San Diego, there isn't one. Now, this program is not in every single county of California. It's only in five counties. So you may go, if somebody moves, they may go to a county that doesn't have the program. So you have to make sure that if someone is in that it is within the same area. Generally, if someone's on the waiting list and a facility bed comes open, it's not, oh, let me look at it and see, let me decide, oh no, I'll wait for the next one. Because if you postpone it, they'll take you off the list. And so then you go back to the bottom of the list. So you may be in a facility, you may live in South Bay, and the facility that has a bed open is up in Oceanside. So that's some of the issues. You always have a shared room. You're not going to get a private room. So there's some limitations. Now, the Veterans Aid and Attendance Benefit will cover assisted living, and it covers quite a bit of it. So it can help augment any payments that the resident makes to pay for the assisted living. There are specific eligibility requirements. You have to have been a veteran and served at least 1 day during a period of wartime. And on the military site, it says exactly what that is. There's also a aid and attendance benefit for the spouse of a veteran that can also help. Now, this program takes a long time to actually get on. There's lots of paperwork and things that have to be done, so it can be really challenging. So at this point, this is how most people feel. They're like, oh my gosh, I'm overwhelmed. I don't know what to do. I just love that picture. So we just say, like, just breathe, hold on. There are resources and help out there. Because once you have the information, then these things seem a lot more manageable. So I put together some of the things that you can do. One is completing your advanced healthcare directives, your financial and your healthcare powers of attorney. Super important to get those done while the person has the mental capacity. Because once someone is diagnosed with dementia or lacks the capacity to make decisions, and those documents you can't execute because those are executed by the person. So when that happens, it can become very, very challenging. So that's first and foremost, get those documents completed and disperse them to all the people that need to know. Make sure that a resident's wishes are known by the family, by the MD, and all of those people, so that it's out there and people know what you want. So super important. I put this in because it's very true that how a facility looks doesn't mean that they provide the best care. Paying more for a facility doesn't mean that you're going to really get better care. We call a lot of the larger facilities chandelier facilities because they look really good on the outside, but it doesn't mean that the care that's being provided is the best. We've seen facilities that look like you know, a place you might not want to stay, but the residents love staying there and they have great care. They have no issues. So don't let the nice facility facade and things sort of cloud your judgment about that, because what the building looks like is not as important as the care that the residents receive and how the residents feel about the care that they're getting. I also always say, keep in mind that facilities are businesses first. They are a business. And if you keep that in mind, super important, then anything that happens, you will be much more clued into, okay, this is a business thing, so why is this happening? Because it's related in some way to their financial bottom line. So keep that in mind always. Because if you look at some of the large facilities, the person who rents the room to you is called a marketing director. So they will often tell you all sorts of things to get you to move in. Doesn't mean that they follow through with any of it. And that often is the case. So anybody who's trying to rent the room to you is very much pushed because this is a business first. So check everything. Really make sure that these things are being done. You can read the survey reports for any facility that you're interested in looking at ccld.ca.gov. That's the licensing agency for these facilities. You can look at their history for years of any citations, their compliance history, any complaints, how many citations they actually received, what numbers of complaints there are. You can get a lot of information from that. You can also contact the Ombudsman's office. Now, we cannot tell you that this is a good facility or a bad facility or whatever, but we can provide you some general information about maybe facilities that are in a certain area, or how do you evaluate a facility when you go? What things should I look for? What should I do? Okay, how am I doing on time? Okay. Tour the facilities, really discuss the price. You have to consider that over time, if you rent a room and you're at, in a sense, a person's max budget, then you're often, and this often happens, suddenly they need more care than they did when they were first admitted, and now they're going to charge more money for that care. So you have to really look at how much is the room rent, then, you know, maybe in 5 years, if they need more care, how much is that going to cost? What's the maximum amount that they could charge you for care? And can I afford that? Because many people get into a large facility and then need more care, and they don't have the money really then to pay for it. Many large facilities charge community fees that can be $2,500. You want to read the contract thoroughly before you sign it, because the contract is there to protect the facility. And one of the things facilities often have in there is that if a resident starts having any kind of behavior, that they can require that the family pay for a sitter, which can cost as much, if not more, than the actual cost of the facility itself. So the key, always read everything, because it will benefit you thoroughly that you understand that. And if there's something in there that you don't understand, you can also contact our office. I also have on here Elder Law and Advocacy, who can certainly also answer your questions. Now, the county has a website called choosewellsandiego.org, where they have tried to put together a rating scale of the RCFEs. Skilled nursing facilities have the 5-star rating from Medicare, but there was no overall rating of assisted living. So how do you choose one over the other? So they have on that site connections to all the licensing reports and the rating that these facilities received, and the criteria is all listed there. Now, what they've done is a facility is not required to be rated. So the facility had to be willing to be rated and have that score up on their website. So if facilities haven't been willing to do that, that might be a clue in as to why they wouldn't want to do that. Okay, this is all free for the facilities. They actually get to, in a sense, advertise their facility on their website and put pictures up and things like that. So it's good to check, are they willing to be rated? And see, all facilities are listed, but it will designate which ones are rated. You have also rcfereform.org, which is actually the organization that the county worked with to put Choose Well together. They originally started a website to be able to help with getting information from, such as licensing reports. Prepare for the cost beyond the initial move-in. Can be a lot of money. So you want to think about, 5 years down the road, are we going to have enough money to pay a bill that may be thousands of dollars more than what we're currently paying? Placement agencies, they can be very helpful in finding a placement. The fees that they charge are charged to the facility usually, so there's no fee for family members. But keep in mind, how much they get paid is based on what facility you go to, actually are admitted to, and how much the rent is there. So I would not give the placement agency the full amount of what a loved one's income is. I would say, I can spend this amount on a room. What can you find for me? Because they will find the most expensive facility generally, because that's how they're going to make more money. So they'll place someone at the max of your budget. So be very cautious. And if it's too much money, say, look, I need something cheaper, very, very often. Now, many of these these assisted livings, they've maybe been to the facility, but they're not really necessarily keeping up to date on what their survey reports are, or, any issues that they're having. So it's important to even check out those facilities and look at their licensing reports and see what's gone on. Even things that they didn't cite them for, it's important to look at those complaints and see what the general complaints are. Because if licensing doesn't find it, it doesn't mean that it didn't happen. It just means that they can't find enough evidence to actually cite the facility, sort of like in a court of law. You have to have enough proof to say that this actually happened. So many times they'll be unsubstantiated just because they can't find physical proof that something happened. So those complaints are super important to look at what they got complaints on. So these are some other resources. HICAP and Elder Law and Advocacy. HICAP deals a lot with Medicare and those issues, but Elder Law and Advocacy is a legal resource that can help with answering questions about contracts. They can review them. They can assist with any of those kind of questions. Then I've just got, these are some things that pertain more to skilled nursing, but they're good resources to have, such as the Medi-Cal number if they have any questions. CalMedi Connect Ombudsman is, if someone is on Medi-Cal and has issues with the HMO, that their Medi-Cal is tied to, then CalMedi Connect can help and advocate for issues related to the insurance company and trying to get coverage. Awesome resources, the Long-Term Care Ombudsman Program. So many people don't know about our program. And we're the ones that are dealing with these facilities on a daily basis. So we know them even more than licensing or placement agencies. So the California Department of Public Health Licensing and Certification, that is for skilled nursing facilities. And there's their website and number. Community care licensing is for assisted living. They license all of the assisted livings, the adult day centers, the daycare centers for kids. They do all of those kind of social programs. Consumer advocates for RCFE reform. That was the website I told you about that has the licensing reports. Choose Well San Diego is the rating. Medicare.gov. Great resource for anything related to Medicare or skilled nursing facilities. HICAP is the Health Insurance Counseling and Advocacy Program. They primarily deal with Medicare issues. So if somebody has an issue with, you know, their drug plan and things are not working out right, or they're trying to get coverage for things, they can be very helpful. Then there's also Consumer Advocates for Nursing Home Reform. This is an awesome website. It is a nonprofit legal website that helps with the regulatory issues and fights for protections for residents in facilities. They have wonderful resources for skilled nursing and assisted living as far as resident rights, things that can happen, things you should look out for, checklists. They have just a plethora of resources for both types of facilities. How do you start a family council if a facility doesn't have one? To all sorts of things that are really, really great. All right, that is the end of my presentation. I'm more than happy to take any questions if we have any time. We're really, really close.
Thank you, Kristin. A lot of really great information. And I appreciate you kind of, you know, laying it out from people, like from start to finish. Especially the things that they need to consider kind of down the road when they kind of start this process.
Well, and much of it is information people don't really want to look at before they're there.
Right.
And unfortunately, you're not going to just be able to go out and find the information. Mm-hmm. It's very hard to, I mean, there's sort of the regulations and what they're supposed to provide, but then there's the reality of what really happens. And that's what I'm trying to make sure that people understand, is that just because it's here doesn't mean that it always is happening exactly the way it should be. And sometimes regulatory agencies don't help. And so it's arm yourself with the information that you need to be able to advocate best for your loved one.
So what is the best way for people to get in touch with you?
I will give you my personal work cell. Shh. Sorry, that's my granddaughter.
She's been really good.
My cell, I work from Tuesday through Friday. I work 4 10-hour shifts. You feel free to call me at any time. My number is 858-229-3262.
Perfect. I'll make sure to include that in the notes for the presentation so people can have that.
Yeah, and you can always call the Ombudsman main line and say you would like to speak to me, then they'll send me a message and then I can call you as well. You can also email me. That's even a great thing. I can give you my email address if you'd like that too.
That sounds good. Well, thank you again. We really appreciate you.
You're
And
very welcome.
as usual, a lot of really great information. We're so lucky to have you. A little round of applause for everyone. We're so
Thank you.
lucky to have you here in San Diego to help our families and people, in need who need these services that you, described to us.
Well, thank you. And if you hear of anybody in a facility, encourage them to contact and find out who the ombudsman is, because even if there's no issues, just the facility knowing that you know about the ombudsman has a significant impact on the level of care that somebody receives.
Mm-hmm. Well, thank you so much.
You're very welcome. Thank you for having me, and I thoroughly enjoyed speaking with you all.
Yeah.
Take care.
Enjoy the rest of your Saturday.
You too. Bye-bye.
Bye. All right, Lisa. Next on deck, thank you for joining us. I am so excited to hear your presentation and the information that you have as well. And I think it's a great pairing with some of the things that Kristin's able to talk about today. One of the things, that maybe we can touch on is, when should families start kind of, looking into, if putting someone in a home is the best fit for them. But before we jump into all that, sorry, I'm jumping ahead. Could you tell us, who you are, your credentials, and, what we're going to be talking about today?
Yeah, thank you guys so much for having me. I'm excited to be here and happy to help you guys out. My name is Lisa Mooney. I'm the social worker for the HDSA Center of Excellence at UC Davis, which is in Sacramento, Northern California. I'm also the Northern California HDSA chapter social worker, so I kind of work, do both hats. I've been working with the HD community for about 10 years. I love my job most days. No, I do love my job. And I just want to help families, and San Diego has a special place in my heart because I did go to undergrad there and got my bachelor's degree at San Diego State. So, so I love it. So Kristin did a fabulous job. I totally want her to come talk to, she basically did my job for me, so that's awesome. But she had a lot of good information, which I think is good. And I don't actually have a formal presentation. I would be happy to answer just any questions. Obviously, I can talk off the cuff about, different things or different recommendations that I would have based on what she already shared, type things, and specifically for Huntington's families.
Yeah, so we can just jump into it, kind of going off of some of the things that she talked about. When do you kind of start encouraging families, when she was talking, I was thinking, a lot of people have to navigate all that information that she just, presented to us when they're already usually in crisis, right? So to have to go through all that has to be a lot.
Yes. So if you learn nothing else from today, I'm sure you will learn more than that. But if you learn nothing else, the bottom line is always pre-plan. So as soon as you get sort of a Huntington's diagnosis or things start to get a little bit more challenging for you, as a family, you really need to sit down and figure out sort of the different options that you might have, both now and in the future, on how to get people to help you with the care of your HD loved one, or help you with the care of your young children so that you can, have more time for your HD loved one. Whatever it might be, you have to come up with some plans. And not to be Debbie Downer, but just for realistic purposes, for California, we are very short on long-term care beds for people, whether it's in a assisted living, whether it's in a residential care facility, whether it's in a SNF or skilled nursing facility, sorry. It takes a long time to find those. If you have money talks, we all know that, but if you have money, it usually will take, 2 to 6 months. If you are using like insurance, like Medi-Cal or assisted living waiver or something like that, it could take years, like 2 years. And it's not just 2 years because you guys live in a house and you're not professionals. It takes me 2 years to find placement for people. So this is just a crisis among Californians and finding long-term care beds. So it really does require future planning. And if you get to the point where you're like, I just can't do this anymore, you are now 2 years behind schedule. So it really has to be, when things start getting more challenging, you're coming up to more barriers, it's taking more time to care for your loved one, you really need to sit down and decide, can we continue to do this in the home for the next 5 years? And if the answer to that is no, then you need to start planning, what your options might be.
Now, as a caregiver, what are some maybe common red flags that they should be aware of when the burden is maybe becoming too much to care for someone?
Yeah, that's a fantastic question, Jamie. So for caregivers, I think the biggest thing is if you start to feel overwhelmed with your responsibilities, whether that's your HD loved one, your children, your job, all of the above. If you start to feel overwhelmed, that's your body signaling to you, or overly stressed, that's your body signaling to you that things have changed and things are getting harder for you. I like to tell my patients, we all have a stress bucket. And we can take so much stress and manage it when it's all sort of nicely in this bucket. But when it starts to overflow, you become really inefficient in managing your stress, and everything becomes really overwhelming, and everything becomes a challenge. I mean, at that point, even showering becomes a challenge for yourself, right? So you really have to make sure, you really have to be in tune with yourself. Some of the physical symptoms that might come up is, you have more difficulty sleeping. Maybe you want to sleep more. Maybe you're comfort eating. That's my gig. That's what I do. If you like to comfort eat, some people go on the opposite side and they don't eat. So maybe they're losing a lot of weight. You start having maybe some headaches and stress related GI stuff, upset stomach, some of those things. Those are physical signs that stress is getting or responsibilities are getting too much for you and you need some help or some intervention. So that's with caregivers. Now with the Huntington's persons, you also have to assess their safety. So if they're starting, if you're working and taking care of young children, which many of our families are, or children, it doesn't matter if they're young, but taking care of children, you have to assess safety as well, because you also have to take care of all, other responsibilities in life. If the Huntington's person is falling more frequently, if they're having more behavior issues that are taking you away from other responsibilities, thus adding, to your stress level, if they're, just having their general Huntington's progression where they can't, do certain things for themselves safely anymore, and you're having to supervise everything they do, like supervise their showers and supervising brushing their teeth and supervising making food and eating because there's risk and that type of thing, then you might need to start thinking about, well, at that point, you really should start thinking about how are you going to get someone in the home to help you out with whatever you need help with. Whether that's your HD person or other responsibilities, and what is your future plan? If your plan is you want to keep your loved one home as long as possible, that's perfectly okay to do. You also just need to have another plan, because it's not always realistic to be able to do that. It's next to impossible to take care for one person, spouse, children, child, I don't care. It's almost impossible for one person to take care of a Huntington's person on their own and take care of themselves. And then if they have other responsibilities like a house or kids or a job or any of that, it makes it even more difficult. So just keep that in mind, that like for me as an HD professional, we want to see families stay together, and we want HD loved ones to be able to stay home and independent as long as possible. The reality of this horrific disease is that just may not be realistic for anybody, for the safety of anybody, whether that's the spouse, paid caregiver, or the Huntington's person, or anyone else in the family.
Lisa, could you speak to maybe families who are doing you know, a good job at taking care of someone, just how many people are involved in helping? Could you so then people kind of have like a tangible example of what that looks like?
Well, as I say, it takes a village to raise a kid, right? Well, it takes a village just to kind of survive life, right? Especially 2020, right? So, you know, if you're one person and you're doing your whole life alone, that's when you need to start building your support system, whether it's asking family and friends to help you with, I don't know, making you a casserole once a week, or coming over and helping clean your house, or taking your trash cans out on trash day, or sitting with your loved one while you go get, I would say, hair or nails done, but maybe you can't do that now with COVID, but you know, maybe so that you can go take a walk or exercise or do whatever it is that you need to do for your own self-care. So the answer is it varies for everyone. You know, some people can have, you know, 15 people and that works for them, and other people just have a few, you know, 1 to 2, maybe 3, you know, people that help them out. It's kind of whatever works for you and your community and your village and what you're needing. But it truly does take a village, and it's not a village to raise kids or a village to care for Huntingtons. It takes a village to enjoy life and be successful and be efficient. So for all of us.
Yeah, and I could see to allow the caregiver to be the best person that they can be, you know, and to provide the care the best way that they can.
Right, and you certainly don't want any of the family members to not be able to fulfill their dreams or to go after their passions in life. You know, most people don't like raise their hand and like, hey, I want to take care of people for the rest of my life, whether that's Huntington's or otherwise. You know, people have dreams and goals and things they want to do, and they need to be able to do that too, because that's what's gonna, you know, fill up their bucket and fill up their heart and give them meaning in life. And we all need to have that meaning and purpose in life. And, you know, of course, there's conflicting interests a lot of times, so we have to make difficult decisions. But it is important that, you know, caregivers or care providers, family members still get to have things in their life that bring them joy, and not just have to be necessarily a nurse all the time, or you know, a parent all the time, or whatever it might be.
Mm-hmm. Again, for people who are successful caregivers, do you find that there are resources that they're really tapping into? Like, you know, are they attending a support group, or, you know, are they having, you know, someone come into the home to provide medical care, or is it, you know, just a cleaning service? Is there something specific that you've seen?
Yeah, well, all of the above, right? So again, it's going to depend on the individual and what it is that you're looking for. But my advice to you would be, the best thing is that you make sure that you are getting at least annual HD care from an HD specialty clinic, whether, you know, whether that's UC San Diego, or you go up to UCLA or Riverside or wherever you go, or you come up to Northern California. But go to a doctor or a team that you trust to give you some advice on the HD progression and things that they're seeing, because those are the professionals that are a little bit more removed from the situation, right? So like, if I only see your loved one every 6 months or every year, I can see changes a lot better than you guys can, because you're living it every day and you're adapting every day. So we can help you sort of identify like, hey, things look like they might be getting a little challenging for you, or at least challenging for your loved one. How's it going at the house and stuff? And then we can start making recommendations on like, hey, have you thought about, you know, trying to find a neighborhood, you know, teenager that can help you with yard work, or find a cleaning lady, or find a support person that can help you, you know, sit with your companion while you know, go do what it is that you need to do. The other thing is, support groups are huge. I would highly always recommend support groups. National HDSA has, I don't know, 10 or 12 support groups a month, video support groups, of course. San Diego has a support group, I believe, that's pretty thriving. And, you know, like, we have support groups all up and down Northern California, or California. And then So it's just important to find your community, your HD community. And the reason finding your HD community is important is because they understand. You sometimes can just give that look like on a video, and everyone in there that, you know, has an HD loved one just knows what you're feeling and what you're thinking. So you don't even have to have the words sometimes to express, you know, the challenges or even the triumphs or anything like that. So it is good. And families have the best advice, right? Because you're living it. Like, they're walking in your shoes, or they walked in your shoes before you, or maybe they're right behind you. But either way, you guys can help, like, hey, this really worked, or this program was fantastic, or don't waste your time. That was 2 years wasted on, you know, going down this avenue, whatever it might be. Families are the best, the absolutely best. I've learned the most from families and I work with fantastic professionals, but I have learned the most from families about just how to navigate Huntington's disease. So, you know, it's important to stay connected. I think education events like this are really important as well, just because they can remind us of things that we need to do. We may all know it, but sometimes education events can give us that sort of fire under our behinds to get us moving towards that direction where we need to go. Certainly stress can cause us all to procrastinate a little bit. So sometimes you need just a little extra push, and education events are really good for that. So these, or national ones, now they're all video, so you can actually join any education event across the country that you know about, which is really kind of cool.
Yeah, it's you know, we've had to adapt, and it's been challenging, but I have found, you know, we are able to reach a lot more people, and also, you know, we hear from so many really great people. Being able to record this and have it be a resource that people for years down the road can access,
Right.
is wonderful.
Exactly. Yeah.
So Lisa, for someone who is, you know, not necessarily the caregiver, but they're seeing someone who is a caregiver, and they're kind of seeing that the burden is growing on that person, what should the person who's kind of removed do to support, to help lead the caregiver to more resources? How do you kind of recommend them navigating that?
Yeah, so also a good question. This is what I will tell care partners. People want to help. They always want to help. They just don't always know how to do it. And they usually always have good intentions, right? But sometimes if you're a care partner, it can be more of a burden for someone to be like, hey, what can I do for you? Because now you have to like come up with like these things that for this person to do, and you have to sort of manage that, and then you have to manage all your other needs. So sometimes it can be a little bit overwhelming, and so you're just like, nothing, you know, go away. But so this is what I tell people to do. When you're not in a heightened stress situation or feeling overwhelmed, sit down and look at all the things in life that you have to do. Wash dishes, clean up a dishwasher, vacuum, you know, lawn, mow the lawn, feed the dog. My dog just barked. You know, take care of the kids, get to soccer practice, medical appointments, whatever it is, write it all down. And those are the things now that when people say, hey, what can I do for you? You can go to that list. You don't have to do much thinking. You go to that list and be like, hey, you know what? Little Johnny has soccer practice on Tuesday, and I also have a medical appointment on Tuesday. Can you, you know, take one of them to, you know, either one, and see if they can help you that way. People want to help, so you just need to give them the opportunity and what to do. And it could be something as simple as, hey, next time you go to the grocery store, can you get me some, you know, necessities, milk, butter, you know, whatever it is that you need, type thing. Because people, you know, are always willing to do that, especially now in 2020, you know, like, you know, whenever I go to the store, I kind of go to all my neighbors like, hey, you need anything? I'm going already. So we might as well just, you know, share the burden of, you know, doing these tasks. Mm-hmm. So, you know, and then the other thing is if you have a very close relationship, so let's say you're an adult child and it's a mom or a dad that you're sort of seeing as the care partner and they're burning out, if you can talk to them about, hey, I'm noticing some changes, we really need to start getting involved and getting support in the house for you and, you know, our HD loved one, then, you know, you can kind of be that fire as well and help, you know, connect them to resources and start that process. The other thing that is really hard for care partners is forms. And I will tell you, there is 1,000,001 forms for everything you have to do or get in contact with, right? So if you are an outsider, not a direct care partner, if you are good at organizing details, if you are good at filling out forms because you're detail oriented, offer up your services to someone that you love, whether they have Huntington's or not, and just say, hey, you might have a lot of forms to fill out. Can I help you do any of this? I'm really good at it, or I like it, or maybe I don't like it, but when I'm watching TV, I'm happy to do that for you, whatever it might be. So filling out forms is a really good way to help people out, or making phone calls, because that takes a lot of effort too, and time. So making phone calls can also be really helpful.
Yeah, I know sometimes the hardest thing is just getting someone live on the phone or
oh my God, yes.
Understanding who the right person you need to contact is. So I could see that being really helpful for someone.
Right, and let's be real, if you're calling Social Security, you need at least probably 2 hours. Do not call them at the first of the month either. If you're calling Medi-Cal, you probably need 2 to 3 hours. It's insane. And here's the thing, and that's even me. So it's not like believe me, if I had the backdoor number, I'd be giving it out to everybody. That's probably why they don't give it to me. But, none of us really have the backdoor. So I have to go through the same horrible, computerized, yeah, thank you. Press 1 for this, and you just have no idea. And then you get to somebody and they're like, I can't help you, I have to transfer you, you're going to be on hold, and you're just, sometimes you feel like you're going in circles, which then adds to your stress, and you want to, throw your phone or computer out the window. But yeah, so if you can get people to help you do that, then that's hugely valuable and hugely helpful for people.
So to pivot a little bit, could you speak to how you're seeing COVID affect your HD families?
Yeah, so COVID, it's affecting all of us, right? So by virtue of having Huntington's does not necessarily make you more at risk for COVID or more susceptible to a severe COVID journey if you should contract COVID. Now, of course, if you're in the later stages of the disease and you're bedbound or wheelchair bound, or you're on a feeding tube or some of those things do make you at higher risk, and obviously if you're over 65. But by virtue of having Huntington's disease does not make you at added risk necessarily. The biggest risk for all of us with COVID, whether we have had COVID or we don't, is the isolation. Isolation is having a huge impact on our Huntington's persons, and it's having a huge impact also on our care partners, because if you do have paid caregivers coming into the home, or cleaning ladies or people helping out, maybe they can't come anymore because they themselves aren't comfortable, or maybe they're higher risk. So people are really having to take on more of a burden. If you have a loved one in a care facility, you now don't really get to visit them much, or you're visiting them through a window, which is better than nothing, but also you lose that human connection, and that's really, really important for all of our health and well-being, and especially emotional health. So isolation is the biggest thing that's really hurting our Huntington's our Huntington's community right now. They're doing some studies, and because I'm a HD social worker, I talk to other HD social workers around the country, and it is a huge issue. And we unfortunately have had an increase in suicides and self-harming because of the isolation and because of change in routine, right? I have a number of Huntington's persons who had their routine, right? Every day they would wake up, they would walk to the coffee shop or walk to the donut shop, or whatever, and then hang out with their friends, and then they'd come back. Well, now the donut shop is closed and the coffee shop is closed, and you can't hang out there. They may or may not remember to wear their mask, and so then they get in trouble that way. And so it's it's uprooted the schedules of everyone, and our brains, Huntington's or no Huntington's, love routine. They thrive on routine, and all of us have had to adapt and make new routines, and everything changes about every, before it was about every day. Now it's like every 3-4 weeks we get like new guidelines and things. So it's the emotional toll that COVID is taking on everybody is really hard. So you do have to make sure that you stay connected any way you can to people. And if you are feeling more and more depressed or suicidal, you need to reach out to your people or to a suicide hotline or something like that. People are here to help. People do want to help, and they will do. You just got to find your person. Someone will help you, I promise.
Yeah. I think when you were talking about routine, I could see how it'd be helpful to, from a distance, try to help someone stay on their routine. So have that be like calling them, kind of checking in with them, and helping them maybe progress through their day. That could be a positive way to keep people motivated.
Absolutely. Those are great suggestions, because that is true. Even if you can't be there in person, you can, help them. And, even before COVID, I found some interesting studies. They've done studies on, is it like Alexa or the Google, the things you talk to that are whatever they're called, smart devices. Those have actually proven to be companionship for people that live alone. So because they can say, hey, Alexa, play my favorite, station, and Alexa knows their favorite station, and Alexa will talk back to them, or Alexa, tell us a joke. So even though it's not an actual person, right, in their presence, it is a form of companionship and has proven in older adults to be in an effective way. Alexa can also help them, remind them like, hey, it's lunchtime, go get your ham sandwich, or hey, it's, time to take your meds, and can do some of those things. So, smart technology, can be helpful. Of course, we can all get, burnt out of it. So you kind of need a balance of all of it, right? But that is a way to add some companionship into everyone's life too.
Yeah, that's another really great recommendation. So we had a question come through the chat. Thank you, Anita, for sending this over. She asks, what methods do you recommend to get your loved one motivated? I see my HD loved one wanting to isolate more, and I want easy and lighthearted ways to encourage them to move around, etc. So,
great question, kind of like the $1 million question, right? How do we get anyone motivated? So for Huntington's person, I'm going to come from the medical side first. We need to check to make sure they're not depressed. If they're depressed, that could be one of the reasons why they're using to isolate. That happens a lot with depression. And if it is depression, then we can start looking at whether medication is appropriate or whether just environmental changes are going to be sufficient to cope with this. The other thing that's very common in Huntington's, I mean, very common, like probably 80% of the people, I think it's like 80%, maybe it's 70, but anyways, a lot of people with Huntington's have apathy, and that's just the lack of motivation, the lack of drive. They're perfectly happy sitting in front of the TV for 12 hours a day, or perfectly happy laying in bed, and it's not that they're depressed and they're sad and that's why they're isolating. They're just more content in that state. Now, apathy is something that we cannot usually medicate for. We cannot necessarily change with medication or anything like that. So that is where we have to do 100% of environmental and lifestyle sort of changes. What I find is best for Huntington's person is if you are the care partner or adult child or whoever you are, and you're wanting to get your HD person more active, is to be active with them. So if you don't live in the same house, maybe it's, hey, it's, 11 a.m. My favorite chair yoga is on, whatever channel. Let's get on Zoom and do chair yoga together. Or if you are in the same house, you know, obviously doing it side by side. The other thing is start small with baby steps. You know, we all need, I'll speak for myself, you know, to get more exercise and more movement and some of those things. And if you're just like, all right, starting tomorrow, it's like no more chocolate, no more sugar, no more carbs, you know, like it's just overwhelming. But if you just start like with one thing at a time, like, hey, I'm just gonna, you know, drink less soda tomorrow, or I'm going to only have 2 pieces of chocolate instead of the whole candy bar, or, you know, whatever it is. So start small. So if it's exercise, what I tell people is no more fast forwarding through commercials. You have to watch your TV show, and when it comes on, you stand up by your couch or a table, you brace yourself, or maybe you sit in the chair if that's more stable for you, but you do some stretching exercises, you know, arms up, arms back, you know, stretch your neck. If you can and you're stable enough, maybe it's you do marches in place or knee raises or something. I mean, you know, commercials are what, 2 to 3 minutes long? Like anyone can do anything for 2 to 3 minutes, right? And then it's done. But if you do that, you know, while you're watching TV all day, you've now gotten a lot more movement and things into your routine. The other thing is getting on that routine. So if you do live with them, waking up relatively around the same time within about 30 minutes every day, going to bed at the same time every day, you know, having sort of set meals, knowing what you're going to eat, so planning it and, you know, having that in place so that they don't have to think too much about what they're going to eat for lunch every day or dinner or anything like that. So having those reminders, but the best thing to do is, and don't phrase things as a question like, hey, I'm going, you know, walking the dog around the block. Do you want to come? That's a yes, no question. So if they say no, you're stuck. What I tell people is, hey, it's 2 o'clock. The dog needs to walk. We need to go take him for a walk. So it's less of a, you know, an option, if you will, and more of just something you've got to do. Now, if they do a lot of pushback, you have to decide what hill you want to climb, right, with the person, and if that's the hill you want to fight for. But, you know, it's kind of up to you. But, you know, the less options you give people and the more you just make it part of the routine, then the easier it becomes.
That's a really important thing that you bring up that I wasn't aware of previously, but I also have some experience with individuals with Alzheimer's. And there's a lot of kind of new information coming through of how caregivers should speak and communicate with someone with dementia or Huntington's disease. So, you know, that right there, the way that you know, say something to someone, you know, not allowing, you know, an option to kind of, again, be more motivating to them. Are there anything else, you know, tips or anything for caregivers that they should do language-wise when they're communicating with someone with Huntington's disease?
So communication is key for everybody. And I will tell you, it doesn't like being the boss. I mean, it does for me because I'm kind of bossy, but in general, don't like to, especially adults, take away their sort of and their ability to make their own choices. But you have to remember, someone that has dementia, whether it's related to Huntington's or something else or aging, thinking and decision hard. You know, it's hard for all of us, but if you have cognitive impairment, it's really even harder, and it's just draining. So half the time they say no, not because they don't want to go or want to do it. They just don't want to have to plan anything. They don't have anything. It's just too much brain work for them, right? So, you know, the more, and you don't have to be mean about it, like, hey, it's 2 o'clock, we're walking the dog, let's go. But you can just be nice, like, hey, it's 2, the dog needs walking, we're going to go out and get some fresh air, you know, and you kind of try to be as positive about it as you can. The other thing is to give, is to limit options. So saying something like, to anybody really, what do you want for dinner? The options are endless, right? You're like Mexican, Chinese, like Italian, like you're going through, you know, all these different options. And for a Huntington's person, their brain is getting confused and their brain gets lost. Like, what? Wait, what was I answering? You know? So if you can tell them like, hey, do you want, you know, a burrito or chicken strips? Or do you want a ham sandwich or turkey sandwich or apple juice and orange juice? Like, limit their options, so that it's easier for them to answer and they don't have to use as much sort of brain power to do it. Some families will have like a list on the fridge of like their favorite foods and just be like, hey, what food do you want today? And they can point to what they want, or maybe it's pictures of the food, whatever, just to make it easier for them so they're not having to make all these spur of the moment decisions. Those are some of the hardest things for Huntington's. If you notice that they're inflexible with, someone knocking on their door, it's not because they're antisocial, it's because they weren't expecting it. And our brains like to know what's coming. And for a Huntington's person that has even more difficulty processing what's going on around them, you just gotta sort of work with that inflexibility and work with the capacity of their brain at that particular moment. So, and just being patient. I mean, honestly, we all need patience these days, but just being patient with your loved one. And, if you take a certain approach and one day it doesn't work, or you have a bad day that day, just everyone take a deep breath and be like, we'll try again tomorrow, or we'll try a new tactic tomorrow, whatever it might be. Just give yourself a break. We're all human. You're not going to be perfect every day. You're going to lose your patience sometimes. It happens. But tomorrow's a new day, or you can, the next hour is a new hour, and you can just sort of reset and try again. That's the story of life, is it not?
Yeah. No, I really like that recommendation of having the food choices kind of written down, because I know a lot of families and people with HD, they'll, ask the same questions over and over again. So I could see, if you have a reference for them to kind of go to, and that's also empowering for them too, I'm sure, to kind of know where to go for information. And it kind of popped into my head also to have maybe the routine for the day on the refrigerator as well. So
Yep.
that person, doesn't feel like they always have to ask, what's next, what are we doing next, that could be helpful as well.
Calendar, whether it's, you can put a big calendar, or whether you put daily notes, a bathroom window, your mirror, whatever it is that works for your family. And that's good for everyone. I mean, let's be real, in 2020, I've myself, it's empty right now, but you can see right here in the corner, that's my meal planning. Do it this week, but but I do that for our family, taking care of a Huntington's person in my household. But it's just important so my brain doesn't have to work. When I get home, I'm like, hey, what are we having? Oh, look, it's Wednesday. I said we were having pasta, and that's what we make. It just makes it a lot easier. And having a calendar and knowing, that's kind of what people want. They just want to know what to expect. And the more you can help your Huntington's person out with that, so that they're not sort of caught off guard, the better. Now, of course, if you tell them that there's a appointment coming up and there's someone that perseverates or fixates on the appointment, maybe you do wait to tell them like right before you leave. So you kind of got to adjust based on your Huntington's person and what's going on with them.
Yeah, could you speak to that a little bit? I think that is something that definitely comes up with Huntington's, maybe more than some of the other kind of neurological conditions.
Yeah, the perseverating and the fixating.
Yeah.
So just sort of think of it as like a loop. So like, your record player is getting, stuck in the same spot. No one knows record players anymore, right? But, or your CD has a scratch, so it's jumping. Beth, you have one, or them. So, it's basically just your HD person. They're not trying to be annoying, I promise you. They have no idea they're even doing it. Their brain is just telling them like, hey, you need to find out what's going on with this. Hey, you need to find, it's like their brain isn't processing necessarily what you're telling them to resolve that issue in their brain. So again, they're not trying it to be annoying, but a lot of times what you have to do as a care partner or a loved one is sort of distract them. So if you have a calendar like Jamie was suggesting, and they're like, hey, when's that appointment with, who's your doctor down there? Dr.
Corey Bloom.
Corey Bloom, thank you. Oh my God, I can't believe I forgot her name. Anyways, Dr. Corey Bloom, like, okay, let's go look at the calendar together and find out when that is, and sort of distract them. And then you can be like, hey, and can we get a glass of water? And that will sort of interrupt that message that's going around and spinning around in their brain a lot. So, you know, it's kind of just, it's annoying and it's frustrating. I get it. I have a 5-year-old. She asks me the same questions all the time. I want to bang my head against the wall. But if you can just sort of distract them with different things that will help them get out of the rut, not permanently, but for the time being, maybe to get you, you know, to catch your breath and sort of, you know, reset yourself. The other thing is if the fixation and the perseveration is getting really bothersome, it's really getting difficult to cope with, go to your HD care team, Dr. Corey Bloom, and let them know, because medication can help minimize some of that depending on what's going on.
I know I had gone up to someone and started talking to them about an event, and I felt bad because their family hadn't told that individual. They're kind of holding off because that was like an aspect that that person was kind of up against. So I felt bad and wanted to, you know, stick my foot in my mouth with that. So any recommendations for that? Someone, maybe I probably should have checked in with the family first to see.
Do you mean they weren't aware of them having the symptoms, or they weren't aware of Huntington's, or both?
So they weren't, so they had Huntington's disease. But the family had an event that they hadn't told the individual about yet.
Oh, I see what you're saying. Yeah.
Because they were so focused, and that was like an aspect of the disease that that specific individual was really kind of dealing with at that point.
Right. So here's the thing. We all stick our foot in our mouth. It's totally okay. You're human. You're not a bad person. It was not coming from a place of bad intention or to throw the family under the bus. Believe me, I've worked in Huntington's for 10 years, and there has been plenty of times that I've stuck my foot in my mouth and I'm like, you know, you have to backpedal and just say sorry and, you know, move forward. You know, I think it is about knowing the families. You can't, there's no possible way you would have known that they weren't sharing that yet or anything like that. You do have to just be a little bit aware, you know, if you're working with Huntington's families that, you know, the families do know best about how to communicate with their loved ones, and they may not share everything in advance because maybe they perseverate and they're just going to drive them nuts asking about it all the time. Or maybe they do share everything in advance. So that's just kind of that's part of the learning process when you're, you know, working with families, any families for that matter, is just learning that. And now you know that you're just like, oops, just kidding. And so sometimes it's just like, how are you? Hey, what's going on? What's coming up? To see if they can give you any idea. When in doubt, you know, don't ask, right? It's like, you know, even if you think someone's pregnant, 9 months pregnant, you don't ask unless they tell you. Yeah.
Definitely.
So, you know, so if you're, you know, you've done it, you've stepped in it, now, you know, now you'll just make a different choice. But it's not, you know, I'm sure you didn't do anything horrible, and it wasn't, like I said, it wasn't poor intentioned or anything like that. You're just making conversation, which is, you know, a very kind and thoughtful thing to do. So just give yourself a break, really.
Thanks, Lisa, for throwing me a bone on that one.
You're welcome.
So we've also kind of touched on the apathy as well as depression. How do we kind of tease out which one is which? And again, are there like red flags that we should kind of be looking for?
So what I tell family members is it's not really, I wouldn't take it upon yourself to figure out what's depression, what's apathy, are they anxious, are they irritable, is this something that's manageable, should we get medication, should we not? Let your Huntington's team be those people, that medical piece out, right? Because there is, apathy looks very much like depression looks very much like apathy. It's kind of, you know, one and the same. It also, too, you have to remember you're in the house or you love this person, so your objectivity is a little bit skewed, right? Because you're sort of bringing in your own feelings, your own observations, and sort of applying that to the situation, which may or may not be appropriate in that situation to figure out if it's depression or if it's apathy. or something else. So I would say let your HD team know or tease that piece out. However, if your HD person is isolating themselves, becoming less social, crying a lot, changes in their sleep pattern, sleeping more, sleeping less, changes in eating habit, eating more, eating less, if they're, sort of just sitting on, the couch watching TV all day, but they look perfectly happy doing that, that's probably more apathy. Honestly, Huntington's persons will get to a point where they don't want to be social with too many people anymore, and that's okay. And they will be allowing you to go to a holiday party and letting them stay home and watch that they've seen 18,000 times. So they're okay with that. Now, if with Huntington's is like sitting on the couch and they're really wanting to go, but they just feel like they can't go, or they're just going to keep people down, or they can't participate in conversation, then that sort of gets more on the depression side of things, where they really have intentions and desires to go do those things, but they just can't for, due to their depression or other difficulties they might be having. So again, it's a fine line. Apathy is going to be, there's not usually suicide associated with apathy. There's suicide, however, associated with depression. So while I can't medicate or treat apathy medication-wise, depression we can treat. So sometimes, sometimes people have depression and apathy. I mean, that's perfectly, acceptable and reasonable for people to have. And then we can treat the depression, and then maybe routine and stuff will help with the apathy stuff. And especially if you've tried different routines and things really aren't changing, that probably means there's more than just apathy going on, that there's, some underlying sort of emotional or behavioral mental health issue that we should symptom that we should address, not issue, but symptom that we should address.
Yeah, it sounds like, really having, a care team behind you is really important. What does a team kind of look like? Like, what kind of professionals should you kind of, be updating them of all these things and of the person's like progression through Huntington's?
Yeah, so there's a couple of things. Support groups are a really good way. They're not medical professionals by any means, most of them. But support groups are a great way just to like stay connected with people, and people will be like, hey, that happened to my loved one and the doctor told us we should try, da 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 da. Don't try anything without talking to your doctors first, obviously. But it can give you ideas, and it can give you that push like, oh, maybe I should be calling the doctor. Because a lot of times what our care partners do is they sort of just think it's not bad enough to call Lisa yet. And the answer is it doesn't have to get bad. We don't want anyone to suffer. We don't want a care partner to suffer. We don't want a Huntington's person to suffer. If things are changing and getting more challenging, and you've tried some things and they're not working, even if you haven't tried anything, always call your team or me, and we can, try to help, navigate that out. A care team, it depends on, where you're going for your Huntington's care. If you're going to a Huntington's HDSA Center of Excellence, you will have usually at minimum a neurologist and a social worker. A lot of times they have other members as well. So for our particular center, we have a physical therapist, we have a psychiatrist that we work with. We actually have 2 movement disorder neurologists. We have a genetic counselor. Genetic counselor is usually also at minimum at HD centers, but we have research coordinators because we do research at our site. So we have lots of people that you can reach out to. In general, most centers are set up where you reach out to either the social worker for general questions, and then that person can get you to where you need to go or get you the answer you need. Sometimes people will have like a clinic coordinator or something that talks to you, and they may be a nurse, they may be a social worker, they may be, a slew of other professionals, but they're also a good person to talk to as well. HDSA has a helpline. You can always reach out to them, and, Jennifer, and there's a new person and I can't think of her name and I feel very bad about that. Anita, do you know who the new person is?
It's probably Allison.
No, it's not Allison Bartlett, you mean?
Oh, no. I know what you're talking.
The new social worker.
Jennifer Simpson took over social workers for Ann Lesterman.
For Ann, but then they hired another one recently. Anyways, I can't remember her name, but bless her heart, she's helping us out and helping all Huntington's families. But you can call HDSA National, and they can either provide resources, and if they don't have the resources that you need because you're in San Diego or wherever else, they will refer you to the person most local to you so that you can get some information that way. So that's a good way to contact them too. The other thing is, if you only work with a primary care doctor, that's okay. Not a big deal. Just make sure as the care partner that you are communicating with that primary care doctor. Now, the primary care doctor may not communicate back with you. That's okay. But it's important for your doctors to know what's going on. So even if it's one-way communication of you sending an email to the primary care doctor because your loved one won't let you go to their appointment with them, or it's you sending an email to the psychologist or psychiatrist or whoever they're seeing, because let's be real, as individuals, we can't always see our flaws. Can't always see our good things either, but we can't always see our flaws, and we sometimes don't have the most realistic perception of what we're going through or what we're doing or how we're impacting other people. So getting a care provider or an outside person perspective is really helpful for the doctors to make, better choices to help you, to help a person out. Did I answer your question, or did I totally get off track?
No, we're good. You're doing a great job. I feel like
okay. I'm like, wait, did I go off the rails? Right. Have my own cognitive issues in 2020.
Have you seen, other families use kind of other, like health support services or, some other experts to kind of help them with their, HD journey? So, what's kind of pops into my head is like working with a dietitian is going to be helpful for some families, working with a physical therapist, any other kind of like support health professionals that you've kind of seen that are helpful?
Yeah, Anita came up with her name, Mary Ann. Thank you, Anita. Yes, Jamie, the answer is anybody you can get on your team, a professional, you should at least talk to them at least once. Dietitians are really good. They can give you great ideas about, ways, what meals could be helpful. They can give you good ideas about, maybe making a big pot of mashed potatoes and freezing them in little servings, or, making, a week's worth of smoothies or milkshakes for your loved one, so you're not having to pull out the ice cream every time they want one, twice a day or whatever it is. So they can give you some ideas that way. They can also give you some ideas sometimes, or occupational therapists for that matter, of like utensils that might work better for your loved one, or plates so that there would be less of a mess, or different practical advice. Support group, family members can also give you some of that advice too. Physical therapists are always good because they're good for the HD person, and they're good for anyone that's going to provide care to them, because they will tell you good body mechanics on how to lift someone or roll someone over. They'll help, the HD person with exercises that will be helpful for them and based on their needs. Occupational therapists are great because they do the occupational, so they can even come into your home and be like, hey, this is really set up really nicely for someone that has a disability or some impairments. Or they're like, hey, get rid of this throw rug or that throw rug, or, Velcro these pictures to the wall, or whatever it might be. Speech therapists are also really good because they can give you, practical advice on how to sort of strengthen your muscles, both for talking and for swallowing. So we do refer to speech therapists a lot. Other therapies, there's going to be other ones. I mean, there's some families that, are faith-based. So obviously they use their faith in, helping with some of these things too. All good. Some people are into sort of more spiritual alternative, Eastern medicine. Again, all good too. And, whatever works for you and your family, just share that with your team. Like I personally, if you want to smoke marijuana or use CBD oil or, you know, whatever, drink a glass of wine a night, whatever. I mean, I'm not here to judge you for that or to tell you don't do that or not, you know, whether it's good or bad. We just need to know so that we can provide support and medication or any other, you know, therapies that, you know, will help you on your Huntington's journey. So it, you know, each family is sort of going to have to do what works for them. But just be confident. I mean, if you want to, you know, if marijuana is your thing, it's fine. There is a stigma, but I think in the Huntington's world, hopefully you don't feel shame around any of that. I mean, let's be real. Sometimes you just have to do what you can do to survive the day. And if that's with a marijuana cookie, have to, you know, like just be safe.
Yeah. It's nice. We are, I feel like, getting more information about marijuana and treatment.
Right.
And it's also, you know, trickling into other, again, neurodegenerative diseases that I think, you know, is helpful for HD as well. So to pivot a little bit, with Huntington's being a genetic disease, you know, and I've seen this in my own family, kind of a difference with how to handle telling young children about the disease. Could you speak to that? And I'm sure it kind of taps into, you know, what we've already been kind of echoing, that it's, you know, it's different from family to family, but maybe if you could speak to what you've seen, you know, and what's been successful with your families.
Yeah. My word of caution is always being open and honest is family secrets never end well. They never have. I've never seen one family secret, like one person be like, hey, I'm so glad they kept that from me. Like it never happens. Now, you know your kid and your family the best, so you get to decide when you choose to tell them. But again, family secrets usually don't end well. And a lot of times you'll think that you're keeping the secret, but kids and other people are very perceptive. So they'll sort of sense or feel like something is going on, especially kids. So they'll sense a different energy, and depending on the age of the kid, sometimes they can internalize that and think, oh, well, mom's acting differently because she doesn't like me, or because, you know, I was bad at school, or I'm getting a, you know, bad grade in my class, or dad, you know, or whatever. So they sort of internalize it. So you really have to be careful. So what I say is just being open and honest based on their developmental age. So of course, you're not going to tell a 2-year-old like, hey, so Huntington's is an autosomal dominant, you know, genetic disease. And, you know, you're not going to go into that with a 2-year-old, but a 2-year-old is perfectly perceptive. They can definitely, you know, sense people's energy. And if things are changing for mom or dad or, you know, grandma, whoever it is, grandpa, whoever it is that they're in their life that has Huntington's, it's okay to say, you know, grandma has, you know, a brain disease. And I would actually name it. That would be my recommendation, because it's easier if we have a name for things, like, you know, grandma has Huntington's, that's grandma's Huntington's. And, you know, it makes her look like she's dancing a little bit, and, you know, sort of just stating the obvious, and then letting the kid ask questions. Every kid will ask what they want to know, and don't give them anything more necessarily. Now, if it's an 18-year-old, you want to give them, you know, a lot more information. But so you just, developmental age, you have to sort of look at it. So if you have kids that are across developmental ages, you want to sit down with each one of them at a different time, so that you can give them specific information. The other thing to do is, when you do tell family, friends, and kids, specifically kids, about Huntington's disease, and you do name it and you call it Huntington's disease, everyone Googles, everyone. And you need to warn them not to. No doctor Googling Huntington's disease. And tell them, like, you know, this is scary for us. You're going to have some questions. I don't have all the answers, but we're going to find them together. And then go to, you know, websites like HDSA.org or Huntington's Disease Youth Organization, or, you know, any of the HD Centers of Excellence resources to find out the answers to their questions. because Dr. Google is scary, and I tell everyone not to do it, and I totally do it myself. And when I do it, I regret it every single time. So, I mean, my biggest thing is family secrets don't usually end well. I understand people are coming from a place of good intention when they don't share it because they don't want to scare them, or they don't want to, make them fear their loved one. That usually never happens when you're honest with them about what's going on. Usually if people know what's going on, they can actually have more patience and compassion for somebody because you don't internalize it. I mean, let's be real. If someone goes off on you, because they're irritable or stressed out or whatever, of course you take it personally. But if you know that they have Huntington's disease, maybe you'll be like, it's just the Huntington's. And then you can be mad at Huntington's instead of mad at grandma or mom or dad or whoever.
Yeah, I found that it's been really helpful when, I have people who need to like vent to me. And if maybe they're starting to go down like a path of, I just don't understand why they're doing this, or like why they would say that was, or do this to me. And I found for myself kind of communicating with them, I have to be like, this isn't them, this is the disease, and really try to, separate the two.
Right. Exactly. And one of the hardest things about Huntington's is physically people, yes, I mean, if they have chorea, they look a little different, but physically people look the same. They look like all of us sitting here watching this, right? So you can't see what's going on in their brain. You can't see that their brain is different. You can't see all the spaces in their brain that have died off because of this disease. And so like when I go to facilities, like, care facilities to do in-services about Huntington's disease, I mean, if I only showed one slide, it would be a picture of the brain of obviously of a persons that have been deceased, but of the quote unquote normal brain, which the normal brain doesn't exist, and then a Huntington's brain, and you can see the stark differences. And I tell people, when someone's saying the same thing over and over, they're not doing it to be annoying. Remember, their brain is trying to rewire and trying to do something different because it can't do the same thing it did 5 years ago or even 2 years ago. So sometimes, and I have the brain hanging on my wall because I'm also human, right? So, I can get frustrated, and I love working with the Huntington's community, but yes, I'm human and I get frustrated and stressed out. And I just have to look at that, take a deep breath, and remember, like, Lisa, they're not doing this to be irritating. They, try a different way. You have to get through to them a different way and try something else. I mean, that's Huntington's for you. Just when you think you have it down, they're going to change the rules on you and you're going to have to come up with something else. Yeah. I mean, let's be real. Huntington's persons are helping all of us, care partners or caregivers, just help with our cognition and starve off Alzheimer's and dementia and those types of things, because we're always having to be creative and think of things. So they're actually, being really valuable in our life.
Yeah.
In more than that way, but really valuable.
I want to be respectful of your time, and I know we're a little past the 12 o'clock hour. Before we let you go, I just wanted to check in with Beth, Anita, Doug. Any questions that you think we should touch on before we let Lisa go?
You're muted, Doug.
So what I've found, I usually attend support group, and support group is a wonderful time to connect with families that are going down a path that you are raising red flags. And my question is, you have some new support group facilitators. Does HDSA provide training just about Huntington's and red flags they need to look out for specifically with this disease to get them to resources before it becomes a crisis?
The answer is yes. HDSA has, I don't know how old it is. It might be kind of old, but it would still apply. HDSA has a handbook for support group facilitators on how to manage, certain aspects of a support group culture and resources and different things like that. Do you have peer-led support groups? Excuse me. Or do you have professionally led support groups? Professional facilitated. So yes, and definitely for them, we HDSA also .org. About when were we in LA for convention? 3 years ago? I don't know. Anyways, 2 years ago, I can't remember. Anyways, when we were in LA, we actually did, and I say we because I was part of the panel. I think it was 3 or 4 of us social workers got together and talked about different scenarios and support groups and sort of how to manage them and how to handle them. Those are available as well to support group facilitators. You guys can email me and I'll search for that, that direct link so you can share. Your facilitators, if they want more information, they should definitely reach out to National, because National does have those resources, but they should also reach out to any other facilitator, that they see sort of, doing support groups and ask for help. I think any facilitator, especially professional facilitator, would help and give them ideas what works for their group and, what they've learned along the way. I'd be more than happy to talk to the person.
And I know
I have 9 professionals. I'm one of 9. We have, 8. Anyways, I'm one of 8. We have professional facilitators for all our groups, and we sort of get together and we talk about different things. I certainly don't know everything. They don't know everything, but putting our heads together, we figure it out and problem solve, and we learn from each other. So.
Well, Lisa, I could talk to you all day, obviously.
Talk to you all day too.
Thank you so much for just letting me fire away at you. You really
absolutely
did a great job fielding all those questions, and we were, all over the board there. So, you really know your stuff, and we really appreciate your insight, and ultimately to, support our HD families. So
yeah,
thank you for your work. We really
of course.
appreciate it.
Well, thank you for you. Honestly, I know what I know because of families. I mean, and I work with some good doctors, but we'll give it to the families more so than anything. But yes, I was very happy to help you guys out here. I love education events. I think these are really valuable for families. So I appreciate all that you've done. And Doug and I got to talk a little bit via Zoom earlier this week. And you guys are doing amazing things in San Diego, some of which I'm going to steal and share with the Northern California group. And just be like, hey, San Diego's doing this. Maybe you guys should consider that. So thank you for all the work you're doing to support, Huntington's families and the community as well. So it's really awesome.
I'll just try and do the best we can. So
absolutely. We're all just trying to, keep our heads above water and, make it through each day and maybe finding some moments of joy. So,
yeah. Well, our best to you. Please stay, healthy during COVID times. And looking forward to hopefully someday soon being able to see you in person.
Right.
Maybe at the next convention and be able
fingers crossed, right? Yeah. Fingers crossed. All right, you guys enjoy the rest of your weekend. Thanks for having me. And Doug has, maybe you guys do too, but Doug has my contact information. So you're welcome to share that with anyone that you want. And I'll do my best to try to help them out.
Great, we'll do. I'll make sure to include it in the notes for this. So
perfect. Thanks you. So much, you guys have happy Thanksgiving to everyone as well.
Yeah, happy Thanksgiving.
I know. Bye.
Bye-bye.